all, I'm going to invite Dr. R. Ramakrishnan. He doesn't need any introduction. He is a mentee of many mentors, and he is a chief advisor of Arvind Eye Hospital, Tirunelveli, and he is my mentor too. It's my privilege and honor to invite him to share his 35-year experience of trabeculectomy. To RK sir.
Thank you, Devendra, for the opportunity, and good afternoon, friends, and of course, the other faculty, Dr. Ravindra and Dr. Indra. It's a post-lunch or lunch time. Everybody is in the queue for lunch, and also most of us are in the trade. That's why we are having a very less number of audience. Anyway, so this session, of course, is one of the important sessions. As Devendra mentioned, doing trabeculectomy is not at all a difficult task, but how to manage or how to make the surgery to work forever, that's very, very important, because that depends upon how you preoperatively evaluate the patient, how you do surgery, and how you manage post-operatively. That's a very important thing. And of course, I am going to talk about the preoperative evaluation and also preoperative preparation and also some of the intraoperative tips that will help the trabeculectomy to work forever. Of course, all of you know very well the aim of the glaucoma therapy is to protect and prevent damage to the optic nerve head and preserving the visual field function. And of course, glaucoma is a surgical disease. Most of the glaucoma is a surgical disease, and it's also the even collaborative initial glaucoma treatment study proves that surgery is better than medical treatment. And of course, trabeculectomy with the anti-metabolite, especially mitomycin C, is the gold standard for surgical management of glaucoma. And even though we have so many types of anti-glaucoma surgery in the recent past, including non-penetrating filtering surgery or minimally invasive glaucoma surgery, sorry, and shunt, but still, trabeculectomy continues to be the most commonly and also most frequently performed surgery for glaucoma worldwide. And because the success of a trabeculectomy also depends upon what are the indications for to indicate the definite two type of glaucoma, it's a primary glaucoma or secondary glaucoma or something like that. And also other main indications are failure of medical therapy, intolerance to medications, and advanced disease and disease progression. And of course, some of the other important indicators, especially in developing countries like India, and also socioeconomic condition is one of the important things. And the systemic contraindications for anti-glaucoma medications. And also, when the rate of deterioration of visual function is rapid enough to damage the patient quality of life. That's also one of the indications. And the contraindications, especially blind eye, when there is a presence of active inflammation, neovascularization, and whenever there is extensive scarring of the conjunctiva, we should better to go for some other modality of treatment. Why preoperative evaluation is important? Because to obtain a satisfactory results in surgery, and you have, as I mentioned, the specific patient group, different types of patients or different types of glaucoma with so many systemic medications. So they behave differently during surgery. And also we have to identify the high-risk patients and give more importance for that patient. And a good interaction between the patient and surgery is very, very important because it's not like cataract. Cataract, you just do, and next day patient will read 6/6, and you forget, and patient is happy, and you are also happy. But trabeculectomy is not like that. It is, we are doing surgery in a seeing eye, and most of the time, after surgery, for about minimum 1 or 2, 3 months, the patient will not read the preoperative visual acuity. Suppose if you are operating 6/6 trabeculectomy, next day the patient will be reading 6/24, 6/12, or something like that. And to have a 6/6, it will take 2 to 3 months. Sometimes it will remain 6/9 or something like that. So a thorough, good interaction between you and the patient is very, very important. And explain about the disease to the patient and also evaluate the other medical conditions like diabetes, hypertension, any other thing. And also history of systemic and ocular medications and determine the risk factors. And also the always better to discuss the procedure what we are going to do to the patient and also explain about the important complications that can happen during surgery or after post-operative period. And another important thing is the outcome, because as I already mentioned, the patient, for patient, any surgery is a cataract surgery in the eye. So they will expect more. Even if you combine with the cataract surgery, if you are putting a very expensive lens, the patient will expect everything to be normal. That's why we have to tell what they have to expect. Unrealistic expectation that should not be there with the patient side. So we have to give a thorough counseling, and patients should know what to expect. Always there should be a bilateral cooperation between the doctor as well as the surgeon, and we should not force the patient to undergo trabeclectomy. Always it should be a bilateral decision. And also we have to all the time tell the patient the surgery is not to improve their visual acuity or quality of vision. It is mainly to reduce intraocular pressure and also to prevent further loss of sight. And of course, about the counseling about the disease and what we are planning to do, and also do not give false hope also. Just very, very important. And also we have to explain about whenever you do a surgery for advanced glaucoma, you explain about tell about what are things that are going to happen, washout or something like that. Consent is very, very important. You have to get a good consent from the patient as well as his relatives. And also main aim is to have a very good successful filtering bulb. And these are some of the important complications. Because suppose unless you know what are the complications, it's very, very difficult to perioperative or intraoperative to plan for surgery. So one of the important complications is failure, then of course wound leak and hypotony, leading to hypotony and other hypotony maculopathy, and of course blood-related problems like blebbitis, blebbitis, blood leak, etc. All these things we have to keep in mind. And this can be avoided, all these complications can be avoided with preoperative planning and modification of surgical procedure and appropriate post-operative management and of course frequent follow-up. So how to prepare for trabeculectomy? As I mentioned, all these things should happen, and also we have to examine the tear film status. Suppose the patient is on long-term anti-glaucoma medication, definitely there will be subabnormality of the tear film, so we have to treat with a tear supplement, and also what are the anti-glaucoma medications the patients are taking. And there, of course, we have to give a detailed attention to all these structures before doing surgery, and of course, presence of inflammation, and the lens status, whether phakic or aphakic and pseudophakic, all these things are important. And then, of course, enhancing success. Two things during surgery is only the use of antimetabolites depending upon the indications, and also post-operatively we have to give topical steroids, and also, as you point out, depending upon the situation, we have to do digital massage, laser suture lysis, release of the releasable suture. And of course, the scleral flap is again one of the determining factor in the success of the trabeculectomy. One other important thing in doing trabeculectomy, so practically what we are, every patient nowadays, most of the patients, general patients, they have diabetes or hypertension, cardiac. They will be on, sometimes normal patients also taking disprin or clopidogrel and warfarin. So we have to ask for the history, and we have to stop them at least for 5 to 7 days with the opinion from the physician. And also a good control of hypertension is very, very important to prevent intraoperative bleeding. and also discontinue anti-glaucoma medication. Why? Because long-term use of anti-glaucoma medication will alter the conjunctival cytology. There will be increased conjunctival hyperemia and also increase in fibroblast, and gallbladder cell will come down. And another thing is breakdown of the blood-aqueous barrier, and and also tape film changes, as I already mentioned. So this will cause increased inflammation, fibrosis, and scarring of the filtering bulb, and leads to the failure of the filter. And that's why we have to use topical. We in our hospital for quite a long time, more than 20 years, we are using topical steroids. Those who are on long-term anti-glaucoma medication, we will stop them and give weaker steroids like fluoromethalone, FML, or dexamethasone, about 4 times daily, 5 to 7 days before surgery. And the eye will be perfectly all right. There will be no congestion, like conjunctiva will be healthy. And definitely there you can see the, appreciate the changes with and without the steroids postoperatively. Definitely this will decrease the number of conjunctival fibroblasts and also inflammatory cells and increase the gallbladder cells. And there are so many studies also have been done, and also decreases vascular congestion and stabilizes the blood-aqueous barrier. And what are the indications? Whenever the patient is on long-term anti-glaucoma medications and in inflammatory glaucoma, uveitic glaucoma, better to give preoperative steroids, either topical or oral or parenteral, and also in acute congestive, following acute congestive glaucoma. And this reversal of this conjunctival cytology after topical steroid therapy. The pads for a good outcome in trabeculectomy is good anesthesia, and kinesis is very, very mandatory. Minimum bleeding. There should not be any bleeding. That's why I told you to stop antiplatelet, and also to control the hypertension, and the low vitreous pressure, and the comfortable patient, and the meticulous handling of ocular tissue, including the conjunctiva, iris, and trabecular meshwork, etc. And judicious use of mitomycin. That's very, very important. There is no hard and fast rule that we have to use certain amount of concentration of mitomycin. This all depends upon the indications, whether the patient is young or old, or also the status of the conjunctiva and type of glaucoma, and also how long the patients are using anti-glaucoma medication. All these things are important before determining the concentration and duration of exposure of the mitomycin. And also definitely a good control of intraocular pressure before surgery with all means, whether with the Dimax or oral glycerin or intravenous mannitol. You have to have a good control of intraocular pressure so that the surgery will be uneventful. And the surgical technique is, of course, a good anesthesia is very, very important, and a good lid separation to have a very good exposure of the surgical site, especially when you do a superior rectus bladder suture or clear corneal traction suture. We use both, but always better to do on ourselves instead of asking the nurses to do it. And also, you can have so much of complication when you do superior rectus, so you have to know how to hold the superior rectus muscle, and because sometimes you may end up with severe bleeding and hematoma, adequate hemostasis, and gentle tissue handling, as I already mentioned. Anesthesia, any type of anesthesia you are comfortable, or even topical, you can do topical with a little bit of conjunctival, subconjunctival infiltration. We can very well do in a cooperative patient. We need not go for subtenons or peribulbar, retrobulbar injections. But so whenever you do a surgery in peribulbar, retrobulbar injection, don't immediately take up for surgery. Give adequate time for the anesthetist to act, and also adequate time to eye become soft and quiet. Suppose if you give 5 to 6 ml into the peribulbar block, and immediately if you take up for surgery, the eye will be so much proptose and you will be tense, and then you will end up with the problem. So always better you wait, and also use of adrenaline, we have to be very cautious, and don't repeat the block, otherwise the volume will be more. The point to be remembered is especially when you add adrenaline, large amount of adrenaline, large amount of salicylic, that will compromise the optic nerve, the blood flow. That's especially advanced glaucoma, we should be very careful. And also the digital compression, always better not to use super pingy or Cohen's balloon. Always do a gentle digital massage is more than sufficient then with all these gadgets. And also inadequate anesthesia, we have to be very careful. The anesthesia of the patient is so comfortable in the table, and repeat blocks should be avoided. These are the key surgical steps. Each step is very, very important for the success of the trabeculectomy postoperatively. Two things. One is, as I mentioned, antimetabolite, then scleral flap formation, and of course the suturing of the scleral flap, either fixed suture or releasable suture, and then forming the AC and look for the potential of the ostium. And of course, conjunctival, in 2 minutes. Incision, previously what we used to take limber-based flap for all our trabeculectomy. So what we come across at that time, it's, we had a lot of, because the bleb is so much of localized bleb, and you have what you call as the ring of steel phenomena. This is what you call as the, whatever amount of itemization use, the bleb area will be avascular. But surrounding that area, there is a condensation of the fibrovascular band around this bleb, and this will restrict the flow of aqueous humor posteriorly. So you will have a localized bleb. That's why the Moorfield people have modified this technique into, they have, instead of going for limber-based, they advocated phonics-based conjunctival flap. So in that, what we can do is you can undermine the conjunctiva, and you can put the mitomycin sponge much more posteriorly, so that you will have a diffuse bleb. Instead of a localized elevated bleb, you will have a diffuse, moderately avascular bleb, and the patient will not have any bleb-related complications, bleb-related symptoms. That's the main advantage of phonics-based flap. And of course, antimetabolite is always nowadays, Devendra is using mostly 99% now injection mitomycin. Depending upon the case, the concentration varies. Minimum, commonly we use 0.2 milligram per ml, 0.1 ml with xylocaine in the small 48 millimeter proceed to the limbus. We inject and wait for few minutes, and then we will do the surgery. But commonly, sponges are used ranging from 0.2 to 0.4 milligram per ml. That all depends upon the type of glaucoma, and also the whether it's primary glaucoma or secondary glaucoma or something like that. So to conclude, a thorough preoperative evaluation is playing a major role in the success of the trabeculectomy. That's very, very important. And also modification of some of the techniques like the phonics-based flap, and also the use of mitomycin much more posteriorly, and adequate ostium, and also doing paracentesis to reduce the pressure. A gentle, controlled paracentesis is very, very important to prevent the sudden anterior forward movement of the lens diaphragm. All these things are very, very important to have a uneventful postoperative period and successful trabeculectomy. Thank you very much for your kind attention.
Thank you, Dr. R.K. sir. The excellent, thorough talk as always.